another little, just a complete different question. You did, which is I loved. Again, this is the brilliance of this paper. It's almost impossible for us to get a 4-hour oral glucose tolerance test, let alone a 5-hour. And you did a 5-hour. But I was a little surprised that there was no evidence in a small cohort of reactive hypoglycemia at the 4-hour mark. And with our lean mass hyperresponders, they typically will have reactive hypoglycemia where they overshoot, and what it is at the 4-hour mark, and often they don't test, but they get a dip in their blood sugar, even though their insulin is coming down. And we'll see them dip down in the 30s and 40s and be miserable because of it, because they've had the 75 grams of carbohydrates, which is excessive for them. And so when you did the oral glucose tolerance test, I can understand in the 21-day cycle, in the P2, they may have adapted already, but in the P1, if you did an oral glucose tolerance test, remind me again, you did that, didn't you?
Yes.
Why did you not see reactive hypoglycemia?
Well, again, just looking at the food diaries of the participants, they didn't have zero. There were occasional meals where they were having carbohydrates, and those in P1, and they would have, what would, if I was to have a guess, they would easily have 50 to 75 grams of carbohydrate in that meal. So they again, it's always say this is a really healthy, carbohydrate tolerant, insulin sensitive group. And so they obviously have some familiarity with being exposed to exogenous source of carbohydrate in their diet. It's just, again, frequency matters as well. They didn't.
For a second there, because what you're telling me is that, yes, there were a couple of carnivores in this, but most of these folks were not, and I'd like to see the individual numbers. If you take a carnivore and see, because in my population, those insulin suppressed, way out there carnivore types who get no carbohydrates and won't even do dairy, they all, and I say all, have reactive hypoglycemia. And often that's a presenting symptom.
Yeah, I mean, that would be an interesting study on itself, but we had, as you know, quite a mixture in that respect. And even the ones that were more carnivore would still have, not very frequent, but would still have a day where they would have, wine, or they would have something carby. So they were not sort of like, devout carnivores in that respect. And yeah, I mean, again, the preference for carnivore was not because of any disease, because none of them had prior disease. It was very palate driven, their ketogenic lifestyles, essentially. So there wasn't this sort of adherence of sort of any kind of like belief system with regards to, oh, I'm more carnivore because of this, or I'm, vegan because of that. And there definitely seem to be taste bud preferences.
Oh, sure. But along those lines, I would argue that this is not a test of carbohydrate dysfunction. This is more a test of, as you said, metabolic flexibility, because under the influence of those carbohydrates, insulin is doing exactly what it should. It's allowing that surge and then correcting things and not overcorrecting. So even though they were eating carbohydrates, this is still within that 21-day parameter, a very healthy population. And yet the paper intimates that it's harmful because their their inflammatory markers went up a little bit. And so if this is a healthy response, why are you seeing and commenting on an unhealthy inflammatory response? Isn't that the way the body's supposed to work?
Well, I would say this, all the responses were normal and healthy responses. If you're incorporating carbohydrates into your diet, and that those shifts were the normal healthy responses that happen when you incorporate carbohydrates into your diet, when you suppress ketosis. We literally, we do state in the paper that none of the markers went outside into pathological ranges, so they always stayed inside of healthy ranges. What we question, and it can only be questioned because we didn't test it, was if this was done for 21 years, what would that turn into? What would that look like? So, you know, we haven't done that.
People are still insulin sensitive by that oral glucose tolerance test. What you never looked at was IR. And I understand the study design wasn't that. But in the clinical space, we're heavily focused on insulin resistance.
Mm.
For example, Ozempic and the GLP-1s, the agonists, are there to correct insulin resistance, to increase insulin production, decrease glucagon, and with a variety of organ-related effects. But that's IR.
Mm-hmm.
What we're seeing here is a normal, healthy physiologic response, and yet the paper somewhat demonizes that response based on carbohydrates.
Yeah, we were looking at you know, if you accept the premise of research that says, you know, insulin and IGF-1 usually coupled together have the highest driver of increasing morbidity and mortality, and markers that are, you know, let's say low-hanging fruit markers in terms of inflammation, them being switched on, as you say, healthily. If you have
let me stop you for a second. You said earlier on that the global inflammatory markers didn't go up.
I was saying these common low-hanging fruits. So we have the growth factor ones, and then the cytokine ones, the CRP and the cytokine.
Right, cytokine ones didn't go up, but what
didn't go up. Yeah.
Vascular markers.
Yes, the vascular markers did.
Of vascular, I'm not even going to call it inflammation, of vascular activation went up. But is that not a healthy physiologic response?
Well, you can, I mean, yeah, just like when you exercise, you can have an inflammatory response, but if you over exercise and you create so much inflammation and you keep doing that, it can turn into something not so good for your health, right? A bit of exercise, bit of inflammation, grow your muscles.
Right, but the way these women were eating at 267 plus grams of carbohydrates, and they had this response when they ate that, but then the response died down. And even within the day, you only had that response over a brief period of time when you were forcing them to eat that. Is that not the body doing its job rather than...
It is. It definitely is. It definitely is. I mean, at the end of the day, what we would, when we see a disease and we call it pathology, it's usually still the body responding how it should respond, you know, dealing with what it has to deal with, you know, in that respect. You know, with regards to, again, you know, so for example, you know, plasminogen activator inhibitor 1, PAI1, you know, although you were mentioning glucose being the big problem for the vascular system, insulin is playing that role there too, because the glucose is, you know, causing this glycation, increasing also heparinase expression in endothelial cells. So this is going to break down the heparin sulfate proteoglycans, you know, which is the perlecan on the endothelial cells.
With two things. We're dealing with a surface transformation on the endothelial cell.
Yeah, and the insulin is actually playing a role in that.
Right, but we're also dealing with a hygroscopic effect on the endothelial cells. My PhD was using this model, infusion of sugar, to create an injury. And then we studied amelioration of that response by blocking platelets. So, you know, that was in the liver. So that's 1990. The model that we used was to infuse, using an insulin glucose clamp, sugar into the vasculature of an isolated liver. And then we could isolate different. So what we then saw was a propagation of the clot. So you saw the fibrin clot developing, which is really what you're looking at. We didn't have in 1990, we didn't know what VEGF was. Yeah. You know, what was his name at Harvard only discovered that afterwards, and it was a great discovery. But we could ameliorate that inflammatory response. It didn't occur in response to fat, didn't occur in response to amino acids, occurred in a dose response curve to insulin and glucose, but actually occurred to glucose without insulin. So it was a glucose driven response and an endothelial swelling, which we could see, and then also the pro-inflammatory molecules on the surface of the endothelial cell.
Well, I mean, I presume were you doing this on a chronic exposure, or were you doing it on
exposure? It was
right?
So both ways, in vivo and in vitro.
Right. So the thing is that glucose will do that. The thing is that when you get, so it's glucose that drives heparinase expression, so you'll get this breakdown. Correct. Right, and so that is
also results in the hygroscopic swelling of those cells, and the breakdown of the cellular microskeleton.
So I'm not negating the effect of the glucose, but the insulin is, you know, is its partner in crime. And so, you
No,
know,
of course, well, insulin's driving it in. I mean, endothelial cells still require.
well, also insulin's actually driving sulfate wastage. So then you're really going to be affecting your heparin sulfate proteoglycans. You're going to be affecting cholesterol sulfate. You know, these things obviously are going to also affect keeping, you know, platelets quiescent, you know, keeping them non-activated. You know, insulin actually affects the vascular smooth muscle cells in their gene expression as well. So
we talk about a capillary level. This is not
right.
in the blood vessels, because what you're looking at there potentially the vasa vasorum, which are another vas vessel.
Yeah.
But again, that the point is that elevation of blood sugar will trigger this effect, whether it is measurable or whether it's due to insulin shoving that sugar into these cells. There is an inflammatory effect, there's a hygroscopic effect, there's a basement membrane effect, there's a smooth muscle effect. But the question is this not just a demonstration of a normal flexible body in the study?
Well, we said very clearly they had normal response, and that's why they normally returned. They didn't look like chronically injured. Our biggest question was, you know, if they moved, and it was like they shifted in the directions of, you know, those particular markers that have a relationship with chronic diseases and that have a relationship with aging. They shifted in those directions, which, you know, one can posit is not a healthy thing, but they didn't become unhealthy, right? You know,
right. But that's the point, is that it was rapidly reversible,
yes,
and it was an appropriate physiologic response to the body under those conditions. And
yes,
the reality is, with an insulin sensitive person, whether they're in ketosis or whether they are in having fluctuations in blood sugar in a diurnal pattern, perhaps during the day, how much harm is that? In other words, if you're eating carbohydrates once or twice a day, but you're fasting for long periods of time, you're going to see that ebb and flow. But you're saying these women are almost perpetually, and you measure them 6-7 times a day, perpetually in ketosis. And the assumption is that that's healthier than someone eating some carbohydrates once or twice a day.
I mean, you know, if you just look at the baseline P1, which was 3 weeks, and then we had the 6 months of just the 4 to 6 p.m. testing, which is quite a sensitive time frame to judge the overall 24-hour pattern, sorry.
Right.
You know, one would think that that's contributed to the profile we saw at the end of P1. And if you accept that that's a healthy profile, and that you accept that it's a healthier than the P2 profile, right? And maybe some people won't. You know, we've just gone by, let's look at longevity data, let's look at animal studies, let's look at, you know, the things that seem to show, you know, lifespan being the longest with health. And it seems to match these markers and their behavior. And so they typically had a 2 meal a day pattern. That was their natural pattern. So it wasn't, and it was definitely more time restricted, you know, in terms of how they ate. I mean, sometimes there were 3 meals in a day in the keto phases, but you could see it was typically quite a 2 meal pattern in general, I would say. And like I said, they did have carbohydrate. They didn't not have no carbohydrate. So again, it's very particular to a healthy cohort, you know, participants there. And yes, you know, this idea of this frequency of exposure of carbohydrates, how often are you spiking it, and things like that are going to play a role. And even still, you know, this study didn't do this, but you know, people's stress levels, you know, and lack of sleep and all these things that are going to affect.
You talk about that one woman who was on her probably menstruating at the time, which is a physiologic stressor. But the question really for me is being in ketosis all the time better than just fasting, doing intermittent fasting and having some.
I presume, you know, that question then comes to, well, you know, intermittent fasting is putting you in ketosis, right? And so, you know,
maybe it's just oscillating. In other words, ketosis is where you preferentially using ketones and fat. But in intermittent fasting, if you're still carbohydrate dominant, it's just really the blood glucose levels that are fluctuating. You're still living on sugar. And even in some of our lean mass hyperresponders, they're shifting back to being forced to use glucose, which comes from gluconeogenesis, and they drop out of ketosis. but they're still metabolically healthy.
When you say they drop out of ketosis, for how long?
Well, whenever we measure it, they can't get themselves back into ketosis because of the amount of the protein that they're eating.
On the one meal or on the regularity of the protein that they're eating?
Both the regularity or even one meal a day, but the load that they're eating. You know, if you're eating like Sean Baker and you're a bump on a log, so-called non-athlete, you're getting a massive load of protein. What do you do with that? And the what people don't understand, and I actually had a patient today. It's an anecdote, but he couldn't get his blood work done early morning, and I want to ask. So let me just ask you this question: was this blood work done fasted?
Yes, it was. It's 12-hour fasted.
And was it always done at the same time each day?
Yes, it was.
Okay, because I prefer early morning fasted because it's the worst time of blood work because it's the dawn effect and everything else. This guy happened to have fasted for 16 hours, and he's a pure carnivore, and yet he was not in ketosis. His blood sugars were high. Why? Because he eats a massive load once a day of protein, way more than he needs. BUN was 37, and that's without renal damage. But that tells me that he's breaking down protein. He's still dealing with the protein that he ate last night. And that protein takes a long, long time to process. And it's not only the protein that is eaten, but there's an autophagy return of protein from his cells and his muscles. So it's a little bit more complex than just being carbohydrates you're eating.
Yeah, I mean, our participants were, you know, again, we were very particular to say the study was suppressing ketosis, and therefore the P1 was being in ketosis. So it wasn't about, you know, a high protein diet. It wasn't about like, you know, we're going to control how much fat you have and how much carbohydrate you have. It's like, you know, it's being in ketosis. And so, you know, definitely there is a difference again in plant matter, but there was a difference even between participants on how fatty meat looked when you look at it and things like that. So there's a difference just there. Women seem to, you know, able to, just in this cohort, able to eat lean, not lean protein, but leaner protein, you could say, and still produce ketones. I presume that's actually because they just carry more body fat themselves, and so they can actually make these ketones. But I mean, you know, they definitely were not eating a high amount of lean protein. You know, that definitely wasn't the case. And I would say that
how long do you think it would take of eating this way for damage to begin to happen that is not rapidly restorable? And I know I'm asking to speculate, but is that 1 month? Is it 6 months? How long does it take for someone who's insulin sensitive to become, the way I described, insulin resistant, where they're not able to restore this right away?
That's a good question. Yeah, a good question. I don't know. You know,
on average, I can tell you in the clinical space, and we're going to be reporting off 1,000 cases on this. It takes on average around 2 years for someone with type 2 diabetes to become fat adapted and insulin sensitive when they sustain this for an eating pattern. It doesn't happen very quickly, but it takes around 2 years. It takes about a year for someone who's insulin suppressed to become insulin sensitive. And I did a video on that a little bit ago of an anecdotal patient. But as a group, these metabolic changes to restore them don't take very long. You've proven that the protective effect is at least 21 days. But the restorative impact is almost immediate within 21 days. But the polar opposite is that it takes much, much longer for people to get into this. These folks have been doing it for approximately 4 years. So that's a very long, it's a reasonable time. It's not a very long time. The question I really have toward the end of this is based upon 2 questions. Have you done any animal studies on this?
No.
Because that would be a nicer, you know, it'd be a simpler way to study some of this. The other question, are you planning on doing any additional, are you actually planning on doing any additional studies? Or even if you weren't, based on this study and the information you have here, what would be, in your opinion, the next reasonable study to demonstrate harm? And what you're looking at is aging, but you're also looking at vasculopathy. How long do you think? Because you've got markers of harm, but they aren't harm.
Yeah.
So For example, the Danish diabetes study that was just published last year had hard endpoints of heart attack, stroke, death of a heart attack and stroke, which defined that as opposed to all these other studies that look at elevations in LDL or elevations in cholesterol, which are markers as opposed to hard endpoints.
Yeah.
At what stage do you believe, or really, what studies are next for you in this regard? Because you've shown markers, but you haven't shown harm or restitution.
Well, I mean, this study, I don't think it would be ethical to do this study to the point that we could see hard outcome of harm. You know, that would be if you believe that suppressing ketosis for a long period of time can produce pathology and real harm, it would be unethical to it's like, you know, doing a smoking study and getting people deliberately to smoke and wanting to see something bad happen to them. So that would be unethical. I guess, you know, that's where animal studies would have their value.
But what is the next study? What is the follow on to this, or is this an endpoint for you?
No, we've actually just completed another extension of this study. So we included more. So we've got metabolic phenotype 1, that's being in ketosis, having never had metabolic disease. Then metabolic phenotype 2, which is no apparent disease, no apparent pathology, but not in ketosis, living one's lifestyle, burning carbohydrates and not sustaining ketosis. And then metabolic phenotype 3, which is a hyperinsulinemic condition, which can range from anywhere where you've got normal glycemia, no ketones, and then veering up to glycemia is going up as well, and the insulin is on the higher of the reference range all the way out of the reference range. So that's this kind of like diabetes spectrum from pre-diabetes through to, you know, overt diabetes. And our ketosage study, these participants, they fall in metabolic phenotype 1 in P1 and 3, and then metabolic phenotype 2 in P2. And so we've taken on more participants with no intervention, just to study their baseline, females who are metabolic phenotype 2, having not lived in ketosis and had a carbohydrate restricted. So they follow the UK Eat Well guideline, sort of typical patterns. And, you know, we've had them test for a few days beforehand, 4 to 6 p.m, the blood glucose and ketones, and got a history in these things. And then another group who are metabolic phenotype 3, being overweight, and then measuring all their markers. So we've now extended open this group, just looking at the baseline. So there's no intervention here. And again, measuring insulin, C-peptide, GLP-1, glucagon. So we've been, you know, actively doing that all the now.
Biomarkers to be able to distinguish characteristics.
So from here, we're looking at characteristics, yes. And we're looking at, because we're actually further interested in GLP-1, osteocalcin, glucagon. You know, this is something that we're further interested in, as well as the testosterone and estrogen and these other markers as well. And so we just wanted to create.
By the way, you did not measure glucagon in the study, did you?
We've just measured now glucagon. We currently are in this situation where the beads assay that says it measures glucagon, we're just like, it can't be actually glucagon. It has to be a breakdown product of glucagon, because it's so unstable. We're not, you know, it's stated that it's measuring glucagon, and, you know, we've got the data on it, and we're just, you know, we're doing some investigations right now on that, because, you know, to measure glucagon, normally, you know, you have to measure it immediately from, you know, the fresh blood, the whole blood, which even the clinical labs that we use didn't even want to measure it, because I think that
glucagon is a standard measure for me, and it is a breakdown product, but it does give you incredibly valuable information.
Yeah. So we are measuring it.
Right, because it'll tell you what the component of gluconeogenesis. I use glucagon all the time to be able to understand what's happening within a patient, together with the other markers, but it's a very valuable.
Yeah, so we are measuring it. We're measuring glucagon, C-peptide, you know, the GLP-1 active and total, osteocalcin active and total. But I bring up osteocalcin, and Ken and I we wrote 2 papers on this, because osteocalcin is actually a GLP-1 agonist. And it's highly affected by insulin and ketones, both of them. It has a role in osteocyte synthesis and release into the bloodstream, as well as
in this population, by the way, there'll be a transition point around 28 to 35 years of age, because the entire bone mineralization stops around anywhere from 28 to 35 years of age. Usually, the number that I remember is 28. So if you're looking at a 42-year-old woman versus a 20-year-old woman, already there's going to be a difference. So age is an issue when it comes to measuring.
Yeah. I mean, we're looking at the release of osteocalcin and its different carboxylated forms, and and then because it is known as it is a GLP-1 agonist, it's also a serotonin regulator, and serotonin affects glucagon synthesis. It modulates the alpha cell secretory profile, and osteocalcin is also it's dietary available in your food and active in the intestines, and it's a GLP-1 agonist in the intestines. Okay.
Did you measure CAC scores in these women?
Did we have
scores?
No, we didn't. No. We didn't do any body scans or anything. So
because that would also be, if they've been living in ketosis for a long time, I'd be very interested to know what their CAC scores are. Because that also helps to determine if they're obesogenic or diabesogenic. And
I mean, what we'll probably do, I think, because we also have another study. So we've done a few things. We've also done a study on extracellular vesicles. So we have to do the data analysis on that now. So we've got the results, but we have to do the data analysis. And we also we've got the ethics and started doing metabolic phenotyping of cancer patients, a broad amount of cancers, but there is a cohort that we are looking at specifically, is brain cancer GBM patients, to have a look at their metabolic profiles. We're not doing an intervention, and certainly we'd never do an intervention of giving carbohydrates.
And then you don't need to, because these are biomarkers and you're trying to correlate that with disease. But that's where the CAC score is of value for me, because ultimately the vascular pro-inflammatory vascular markers that you measured, which were the predominant ones that went up, they are going to result predominantly in atherosclerotic heart disease. And that's what we see in the diabetic groups, in the hyperglycemic diabetics. So again, that is the one place where you can correlate this, because we don't see it with all the other inflammation. It's only a 21-day study, is really vascular inflammation. And vascular inflammation and maybe neuropathy, where these markers are the most dominant. And that's where I'd love to be able to see if these women had pre-existing cardiovascular disease or not. And that's what I use for my cohort. My obese patients often have a 0. I'm obesogenic, and my CAC score is 0. But other folks, I've got a guy right here on my desk who's skinny, type 1 diabetic, but his CAC score, I'm going to call him in a few minutes, is 3,388. And he didn't know that. And again, you look at him and he's kind of a picture of health, he exercises, but that is where the markers that you're seeing, and this is important, is that this elevation in vascular inflammatory markers are profound in him, but in me, they're non-existent. And I don't know if an obesogenic person, they're elevated or not, but they certainly are not having a vascular consequence. It may have a clotting consequence on the venous side through stasis, for example, COVID, that kind of thing, but they don't have a vascular impact in terms of atherosclerosis. So it would be very interesting to see what that, do you understand where I'm coming from?
Yeah, absolutely do. And I certainly strongly thankfully my participants have been very willing, in the sense of I would like to carry on following them over the years to see what, how their health turns out long term. And so this
group. So here's just a little study that you can do. If you take the 10, you've given us averages, but we don't know what the range of, is there a biphasic, some group have a slightly higher elevation of your vascular inflammatory markers, others don't. And then the question is, does that correlate with a positive CAC score versus a low CAC score? Because you've given us a global mark over 10 patients or 10 people, subjects, but you don't know what their genetic background is in terms of hyperinsulinemia versus hyperglycemia. In other words, there's no You haven't, and it's only 10, but you haven't created that bimodal phase.
No, we haven't. And I mean, we have PBMCs, peripheral blood mononuclear cells, and so we are doing sort of much deeper analysis from these. You mentioned earlier receptors and intracellular.
Right, but if you sub-cohort them, and again, the very, very simple test, which is a gross test, but do they have plaque or do they not? And if they have plaque, and you might even set a score of 50 plus, or an Agatston score of 50 or 100, versus those that have a 0 or under 10. And the LMHRs, typically the Dave Feldman studies, they had low, and then he showed that high cholesterols don't correlate with an advance. But then you can correlate an objective measure of vascular injury. Are those the folks that have the highest levels of pro-inflammatory markers when they eat carbohydrates, versus another group that eats the same amount of carbohydrates, but they don't have that response? Even if you look at those 10, is there a division between those? In other words, does everybody's numbers go up? Or are there some that go up and the others don't? That would be very interesting information, because it negates some of the inflammatory study that you've done here.
So I mean, Feldman, Norwitz, and Sotomayor, they're doing that study, right? Looking at the coronary artery calcification and lean mass hyperresponders. They're actually, I think, if I'm correct, they are doing that study. We actually have a paper in submission right now in peer review, which is looking at this data and looking at lean mass hyperresponders and predictability of this and its relationship with energy and LDLs and all of that. And Adrian, who is, fantastic with statistics, is looking at these like subcategory relationships, looking at our participants. Do you have, a group of them who have, this pattern versus that, these tendencies, these cluster patterns because we've certainly if you just look at the raw data, there definitely seems to be some interesting things going on there. So we definitely have to do sort of, I always call it sexy statistics, in terms of
the part that most people even working in this field are unable to do or haven't seen yet is the separation of these two cohorts. When you talk about prediabetes, that is not a word I ever use, because you may be have a slightly elevated A1C, but never going to be diabetic because you're obesogenic, whereas the others are. So I use the word insulin resistance and then a threshold crossover of a 6.5.
And it's funny you should use the word insulin resistance, because I don't like this pre-diabetes either, but I use the word hyperinsulinemia.
But hyperinsulinemia is high insulin production and low insulin. So you can be hyperinsulinemic. Everybody. You
see at the same time, we define for us in what we're doing here is actually, we were saying, once you start suppressing ketosis, this is a hyperinsulinemia state, right?
But the question is there a threshold to that where, I'll take my most obese people and they can produce massive amounts of insulin. You know what my highest fasting insulin was? Now, this is not in pico, this is in IU. I don't know if you can correlate to that. 87. An insulin of 87 units of insulin fasting at my fattest. But my blood sugar was normal. So whereas other diabetics can get up to 10 or 14 maximum insulin. So yes, they're hyperinsulinemic, but they're low insulin producers, and they're going to have, at least my prediction is, I don't know the numbers because I've never done the testing, but I would predict that they're going to have those low hyperinsulinemia with hyperglycemia are going to have the markers that you saw, whereas people like myself will not have those markers despite a carbohydrate load. And so when you look at for example, you're doing the study in cancer, we look at the cancer-prone people, and they tend to be the high insulin producer, low diabetic group. Whereas your diabetics are saved from cancer, but they're going to have the cardiovascular markers. And that is a postulate based on clinical observation.
Well, also, I mean, that said, still the diabetic over time, the longer they are diabetic, the higher the rate of them having cancer too at some point. And the longer they've had diabetes, there's
always a crossover.
And the worse outcomes they have with cancer if they were to get cancer.
But the
ones that are most likely to die of cancer without diabetes are those obesogenic ones.
Yeah,
Whereas the diabetic,
and therein lies the problem, because often there is no detectable hypoglycemia in cancer. Therefore, oncologists and researchers don't see it as a metabolic disease.
Because they never measure insulin or C-peptide.
Exactly.
And
exactly.
you know, if you've got a C-peptide of 80 and you've not a C-peptide, sorry, an insulin of 80, a C-peptide of 3 or 4, and you're normoglycemic, those are the guys that are most likely to get cancer, at least in my observational.
Yeah, absolutely. And that's why we wanted to create this study, and so that we could sort of hopefully open that sort of page for oncologists to see, there's something that's not matching healthy physiology here, and hoping that
what I would urge you to do under that is don't pool the data, fractionate the data. In other words, look at the range and see if there's kind of a bimodal distribution versus everybody's just elevated.
I mean, this is the next population. That is one of the next papers that we intend to do. So the first set was the pooled data. I mean, it was within participant. So, repeated measures within participant, the way that we measured, but the way we present the data is in the pooled data. But that was the sort of first step on getting this out. The next step is to do a much more sort of granular, looking at all the relationships within each participant and their markers, so that you can actually really see these patterns there. And that is a plan to do that.
Right. So I'll give you the hypothesis that I would work on. And again, this is something you can record and look at, but this is the clinical data that we have from literally tens of thousands of patients. And we do blood work. I mean, I've got blood work everywhere, just pages and pages of every patient gets all these markers every time. So we've got huge amounts of data. But here's what my prediction would be. First of all, CAC scores, you can have your positives and your negatives. The group with positive are going to have moderate hyperinsulinemia, and these markers, the vascular markers, are going to be elevated, and they're more likely to have cardiovascular disease. The hyperinsulinemics are going to have the lower CAC score and the lower level of vascular inflammatory markers, and probably the higher level of non-vascular inflammation, the other markers you've seen over time, and they are going to have a higher incidence of cancer, Alzheimer's, or mental health or cognitive impairment, and also a higher level of autoimmune disease. So, and also in the females, polycystic ovarian syndrome. That goes together with a high insulin producing normal. Now, obviously, there's a crossover, but I would predict, or my hypothesis, that within this group, you're going to see a bimodal distribution based on those parameters, and there'll be correlation. So I can look at someone's blood work and predict what their CAC score is going to be. And again, most of the time you're accurate, but if you don't do this every day clinically, if you pool everything, you're not going to see that polarization, and that's going to muddy the water, because your average will be different than two separate numbers like this. So again, that is, part of the reason for this discussion is I would love for you to do that work. I've got the clinical observation stuff. You have the ability to go and measure this, but if you don't see what I've seen, I can't see into the beautiful data that you're producing. Does that make sense?
It does. And like I said, when we did our statistical analysis, it wasn't pooled data. It was, each was within their own, because of how they measure, each participant is against their own baseline. But obviously, as you say, you saw our data is presented as a pooled data, so you can't see these patterns. And you're right. You're absolutely right in terms of you can just see it. It's only 10 participants, and you can see there are participants who are responding differently. There's patterns within it. Just with your naked eye, you can see it. So it definitely, we need to do that type of data analysis.
That's where, what you've presented here are numbers. I would love to see a scatter plot of, it's 10 people. What do the 10 look like? And is there a slight distribution this way versus this way? And then how does that correlate with some of the outcome metrics that they may or may not have? And once you deal with those physiologically sicker people, in other words, your type 2 and type 3 phenotypes,
that's where you're going to see a greater prevalence, because that's already correlated with disease. The ones are not necessarily going to have that disease, but the threes should have, and you'll be able to see that polarization, and that'll corroborate what we're talking about. So we've gone a long time. We nerded out a little bit. I'm sure you're going to have to sleep in tomorrow. You call in, but this is brilliant work, and we are so far ahead of people still looking at lipids and cholesterols. I think this is, again, I reiterate that this is one of the best studies in this space I've ever seen because of the biomarkers. But that is where a clinician and a scientist, although I think myself as a science clinician, can help you to look in even a more refined way at some of the data that you have. Does that make sense?
Yeah, 100%. Absolutely.
Adrian could probably spend 10 minutes and get the data.
Well, I started working with Ken in 2020, and it was actually really Ken who pushed me out of my happy little biochemistry zone. and Ken was like, now clinically, look at it clinically. What would you recommend clinically?
Well, but you can make, from the science part, you can make predictions of the clinical pattern, because ultimately, if you have a certain biomarker set, I'll just give you an example of how I use it. If I see someone that's obesogenic with a 0 CAC score, I will tell you, in fact, I use this word now, it is malpractice to put that person on a statin, because they've got no risk of a cardiovascular event from plaque. All they're getting is the liability of the drug. But if I see a diabetic with a high CAC score and these inflammatory markers, I'm not going to advocate for a statin, but I want to put them on an Ozempic. I'm going to put them on a GLP-1 agonist, because that does reduce the impact of this disease. So I can, as a clinician, can use different methods. Obviously, the baseline is a ketogenic diet. But from a therapeutic intervention perspective, that can change how you manage the two different populations. And that is important. Plus, also, the obesogenic people, it's useless to track their blood sugars. So CGM is no value. Because when they walk past a donut, their blood, they gain 5 pounds, but their blood sugar is stable. Or up like they'll be a 2 or a 3. But the diabesogenic people, that's where you want a CGM, and it's not a good idea to track their weight, because they don't gain weight.
I mean, I do have people test their glucose, but it's like I always say, if you're not testing your ketones, there's very high chance your glucose is totally misleading you. And
on the flip side is that, again, this is the fastidious carnivores may not be in ketosis, and you got to figure out why, and is it harmful? And that is, again, that's where our blood work comes in, and we're going to be. We've got the studies done. We've got a sponsored study where we looked at 5,000 patients, which is a big N, and we've able to subdivide some of the stuff. But I would love the corroboration that you have. You see, the one thing I can't do is those inflammatory markers. One final question is, and this may be something you write about or something you can speak about, but what if you were sitting in a clinician's chair and you've looked at a lot of data and beyond even what you've published here, what are the essential markers that you would look at, blood markers that you would look at, to be able to say that somebody is metabolically healthy versus somebody that is not metabolically, that is at metabolic risk, both for aging, but also the aging related diseases?
Again, because you're asking, is it a clinician view or my view? Because I do very quickly look at insulin IGF-1, and I'm familiar with the numbers and its relationship with a lot of the other markers.
The IGF-1 is not something we test for, but you would, because I look at insulin, glucagon, A1C, and blood sugar.
Yeah, which I look at all of these. Right. Absolutely, they're always automatic. But
IGF-1 is something we can test for fairly easily.
You see, again, A1C, you yourself would know, it picks up a fraction of people. It misses a whole load of others.
But A1C still gives me valuable data.
Oh, 100%. And I would always, it's always in the list that I recommend people to do, 100%, just like, GGT. I would never want.
Gamma glutamate transferase is so important. And the only thing there is you've got to remove alcohol from the equation. But gamma glutamate transferase, AST, ALK-FAS, and ALT, those are my liver markers. But they really, and then together with triglycerides. But what would you look at of the data that you're looking at?
I do look at, I mean, I do, you know, again, if someone's supplementing, it's going to throw some curveballs and things like that. But I do look at vitamin D. I do look at B12. I look at mean corpuscular volume, you know, erythrocyte sedimentation.
So let me stop you for a second. Let's look at D3, because almost always, it is very rare, no matter who you are, to see D3 in the normal range unless you're supplementing.
Our participants had good D3 ranges.
That's what I mean. Listen, we do D3 on everybody, and it's extremely rare to see. Now, my range for D3, I don't know what units you use, but I'm looking 40-80 is my normal range with a normal calcium, and the range tells 9.5 to 9.8.
Ours were plus 55, like they were plus 55s in ketosis, like they were.
Right, and that is not ketosis. That is fat adaptation. Because vitamin D, as you probably know, is a steroid hormone. It's not a true vitamin, and the steroid hormones are regulated by insulin.
Yeah. Well, this is exactly it. So, you know, the simple fact that, you know, obviously, if you're making more fat cells and you have more insulin, you're going to be sequestering that vitamin D, you know, into your fat cells as well as increasing excretion and decreasing activation and. You know, a whole load of things that dysregulates, you know, its uptake, its synthesis.
Yeah, the D3 I very rarely see, or even the D2s and D1s, we test them all, very rarely see them in normal range without supplementation. In the full cohort, the full spectrum of our patients, it's one of the most commonly supplemented products out there. And the one that's probably most over supplemented is magnesium, in my opinion.
Yeah, and you know, I mean, I'm always cautious with supplementation as well, and again, if you're going to supplement, and if people are, again, you know, with D3, it really does need K2, meant that, you know, and it's why it's such a difficult path to tread in terms of, you know, when people say, I'm just going to take, you know, D3, or you recommend it, but you don't recommend the other things that I may need. And usually I'll throw in there as well, people who are hyperinsulinemic or insulin resistant, they will either have gastritis, hypochlorhydria, acid reflux, esophageal pharyngeal cough reflux, any of these, which are basically hypochlorhydria conditions, which is
those are all GLP-1 or incretin mediated. Again,
well, those conditions are going to result in poor absorption of, you know, your minerals, your fats, you know, it's going to.
I think the relative absorption, the question is it poor absorption, or is it a function of their dysmetabolism? I mean, we can discuss that at length as well. So it's not a linear thing. There was something else I was going to ask you. Lord, what was? Oh, the other thing that this study is really effective at, and what I love about it, is that by definition or by entry criteria, your subjects could not be on any supplements or additives, and yet they were metabolically healthy. In my clinical practice, I don't ask people, are you taking supplements? I ask them, what are you taking? Because it's very rare that anybody's on nothing. And these folks were about as healthy as you can be by our understanding.
And they're the same people who are not taking birth control, which is so rare.
Exactly right. Wow. Yeah. So now, I mean, they need to socially distance themselves from warm toilet seats, because pregnancy is a side effect that may occur very easily.
That may occur, yeah. Well, you know, I mean, it's just, we, you know, as a study, we didn't time it to the menstrual cycle, because usually that's, you know, the done thing for females as well.
Yeah, but it doesn't much matter. You want to look at that across the spectrum.
Exactly.
I wouldn't necessarily throw out someone with a speculation that it's a period thing. I would incorporate that in the data. You don't want to subdivide that data. But the point I'm making is that all of these women were about as healthy as you can be as a cohort without supplementation.
Very much so.
The majority of people in the space, primarily driven by internet fear-mongering, are taking something.
Yeah, and but this is exactly why we studied this. You know, we were wanting to study naturally healthy, not metabolically dysregulated people, and, you know, who sustain ketosis. So, you know, just like, you know, you have groups who go and study athletes with the assumption that that's the healthiest thing, and, you know, the most, you know, it's the same idea, in the sense that we were wanting to study exactly that, like super healthy people. And I would, you know, presume that if you've got to the point where you're supplementing, you might be thinking that you're not well, there's something not right with you, that you need it for some reason, you know, in this sort of form. But, you know, again, women who have chosen to be in ketosis are probably quite conscientious about their diet and the quality of their diet. You know, it's not, it is, you could say, quite an abnormal nowadays thing to choose to be in nutritional ketosis.
Well, I mean, these women are supplementing, but they're supplementing with food.
Whole food, yeah.
So, but the one other misnomer, probably the greatest criticism I have of this paper, is the use of the word non-athlete, because these women are not athletic, they're not non-athletes, and again, because I think that the question is it all diet or is it physical activity? As you said, study the athletes, but their diet may be carb loading, and they may have type 2 diabetes, even though they run marathons.
But at the same time, these women didn't change their activity when they...
No, they didn't, but they were, as part of P1, and maybe even as part of the rapid response to P3, was the triaging of the substrates they were consuming toward use rather than storage, because they were more physically active on a opportunistic level as well as an intentional mechanism. So they were intentionally doing some physical activity, and because it's what they do, they didn't consider it out of the norm.
Well, we did dig when we were asking in terms of their activities, you know, and it was measured on this. So one of our researchers who's a sports scientist, who was consenting and looking at the activity in terms of, you know, would you class this as an athlete, you know, and what do you consider?
People are more likely to use a set of stairs than the lift or the elevator in my language.
And again, because, you know, we're looking at this concept of sedentary. Sedentary is to minimize your activity, right? That is literally, otherwise we would have said, you know, sedentary women, but then they were not sedentary women. You know,
But I would have used the non-athlete, to my mind, describes, and again, if other people are reading this, oh look, if I eat right, I don't have to be physically active. I can sit and watch TikTok all day long. So again, I'm very cautious about. I understand what you're saying, but there's no way that this group of women is not fit.
Yeah, I mean, and you could see that. You could see that in their BMI. You could see that in their fat percentage. You could see that these were, you know, lean, fit women. But that's still not the same. And I understand, you know, it's like we could have said not sedentary. Maybe we could have said not sedentary and not athletic. You know?
If I eat right and I'm in ketosis, I don't have to do anything. I can be a bump on a lot. And again, it's like what I'm looking at is who's the reader, who's the recipient of this. I understand what you're saying. But I had to interpret that these women were not non-athletic, if that makes sense.
Yeah, but I mean, again, our cutoffs for athletic is different.
Of course, we didn't define that. And, you know, I don't consider someone who runs a marathon an athlete. I consider them to be nuts. But I consider myself to be moderately athletic because I do something physically active every day. So again, it's perception and it's word use. But to disconnect, and I understand what you were doing here. You were purposefully choosing a cohort that wasn't athletic in terms of purposeful endeavor. And that, but again, by trying to distance yourself from that, you may have pushed it across too far. And these are just, I mean, listen, I come back to my premise that this is one of the most brilliant papers by design and by reporting. So what I'm looking at is I have to step into the Harvard, the Chan Public School of Health's shoes and say, you know, what commentary can we make about this? And these are little things, because pushback you're going to get. And unfortunately, this won't appear in front of the US Dietary Guidelines Committee because it's so polar opposite to what can possibly be true. So I'm looking forward to the future studies, but this is really good. And I think having an outline of the health parameters that a clinician can test would be very useful. And I'll probably sit down with this when we release the video and maybe even make that up based on this. I'm not going to look at VEGF levels, but the IGF-1 might be a very useful test. And the plasminogen activators may be a useful test that I can comfortably do and order as a clinician. Just like I understand what you said about glucagon, but the value of a glucagon-like peptide
as a measurable is a very useful thing for me clinically, even
I
though
mean,
it's not.
I work with a lot of cancer patients, and watching IGF-1 and the binding protein, IGF-1 binding protein, so insulin, you know, all the typical ones we spoke about, but looking at IGF-1 binding protein, looking at mean corpuscular volume, ESR, erythrocyte sedimentation rate, serum albumin.
I don't find that, but the cellular size, especially if they're not thalassemics or anything else, but those we look at, but that really speaks to iron, folate, and B12.
But I typically see it in cancer patients, actually, that they'll have a high mean corpuscular volume. And when you start correcting, first of all, just going into therapeutic ketosis with a, you know, nutrient dense diet. So we're not just talking about just being in ketosis just because you consume, you know, extra fat, extra oils or exogenous ketones, with really focusing on nutrient dense, bioavailability, correcting other things like achlorhydria and all the other stuff. These markers shift back into either healthy range or lower healthy ranges, you know. And the IGF, what with regards to looking at you know, whether you're using PET scans or thermography in terms of inflammation and cancer. So in cancer, where, you know, inflammation, if you're using thermography, there's a relationship with IGF-1 and IGF-1 binding protein, which you can modulate through keeping insulin as low as you possibly can. And you'll also see those other changes like mean corpuscular volume, you know, coming back into a healthier range.
But you're looking at MCW, you're looking at RDW, you're looking at a variety of different red cell markers. And the question is the function of bone marrow stimulation after chemotherapy. Is it a radiation? So
well, this is it, you know, again,
low iron because they're losing blood from a GI. So on the clinical space, I've got to look, I never look at one criteria. I tell a story. So if the iron's low, what's going on? If they're you know, the red cell shape is, are they Italian and they've got thalassemia or spherocytosis? All of those things are phenomena that occur. Did they just donate blood? Have they had blood work done? So the iron is low. All of those,
and that's it, because that's the point. It's a whole body. It's a global. It's
but that's where the IGF is a useful marker that supersedes some of those nuances.
Oh, absolutely. It's one of the ones I pay very close attention to. The IGF and the binding protein.
I'm gonna be, if I can get our insurance companies to pay for it, I'm gonna test for it. Because a lot of the functional medicine doctors are going to do CD4 counts, and I find unless you got HIV, those are relatively useless in the space. But they love
in terms of bang for your buck in terms of markers. I would definitely say IGF-1 and the IGF-1 binding protein. That's you know, I can, alongside having insulin and glucagon, C-peptide, you know, the usual HbA1c, alongside having those, it just gives you so much more information, and you can track and really see it in relationship to disease management, progression, regression in that respect.
Everyone does CRP. I never do CRP. I never do the lipid profiles because I can tell from that. I think that's the marker that I will look at. And again, as we make recommendations based on this paper, it really is, the recommendations are twofold. It's what should a clinician look for in terms of blood work analysis to look for potential harm in someone who doesn't look ill or metabolically challenged. And then secondly, how can you help somebody who is a subject who wants to change? How do they drive this, and how can they monitor the improvement in their health? And so often people do ketogenic diets that they found on the internet because there's nobody really focused, and that can also create a degree of metabolic dysfunction. So you can look at this as an objective scientific data set to say, okay, you know what, let's bump up your fat, let's bump down the sugar or the protein, or whatever it may be. So that's how we use the blood work. And so I think there's a call to action both ways, because ultimately a paper like this has to have a call to action. And there's a call to action to clinicians is, hey, look at these, don't look at the standard lipid blood work, because this is going to tell you more about vascular injury than LDL and cholesterol. And to the patients is ask your provider to see if you can measure these, even if you're going to pay for it out of pocket. Drink 2 less Starbucks coffees and you can pay for this blood work out of pocket.
This is
So I love this. Thank you. I know we've talked at length, and it sounds like both of us nerd out quite a bit. Anything that you wanted to add, any comments or questions from your side? You've sat very patiently through this, and you're the most knowledgeable person in the room right now.
Thank you very much. No, it was terrific. I enjoyed it all. Obviously, I don't know if you know my background. I was a neurologist, and for 25 years, all of my patients had 5-hour glucose tolerance tests with simultaneous insulins. And I got to know Joe.
Way back. We have to fight to get the insulins done.
Right. And Joe Kraft and I became friends. So we've been into all road. And the way I ended up with Isabella is I was looking at the relationship, because I also work with the Hospital for Special Surgery in New York, looking at bone disorders. And so I had this thought, and because Catherine Crofts got her Ph.D. on the Kraft criteria, I contacted her and I said, I think there's a connection between what's going on with the blood sugar and osteoporosis. She never really had time. Then came COVID, and she said, I think it's time for us to look at it. Do you mind if we include this person, Isabella Cooper? I said, the more the merrier. And that's what started my relationship with Isabella, which has been an absolute great experience for me. So, yes.
Yeah, it's interesting how paths cross, because when I was in Toronto where I did my PhD, the lab next to me was an osteoporosis lab, and they were looking at bone regeneration versus bone reabsorption, and I learned phenomenal amounts. Even though I wasn't directed to that, there was a lot of bone work being done. This is the late 80s, early 90s. So it's fascinating how these things cross over. The Kraft work, we've relied on. We were talking about the 3 different, the 1, 2, 3s of the phenotypes. When I look at insulin resistance, I've created in my own head IR1 and IR2, and then diabetes. IR1 for me is elevated insulin but normal fasting blood sugar. IR2 is where insulin can no longer control blood sugar and your fasting blood sugar is elevated. And then diabetes is where the A1C goes up. And then you've got the IR5, which is insulin suppression, as well as type 1, in a very similar profile. So again, that's how I look at Kraft. And I can look at obesogenic, which if I remember correctly, is a 3B. I've got a slide on that. And then the 3A is more on the obesogenic, or it might be the other way around. But that's the way that I look at those. I don't do oral glucose tolerance tests that often, because the other metrics can tell me where you are. But if I'm not certain, I can use it to sort through things. So, that's the way we look at this. And I just love the camaraderie and the different routes that people come from. That story that you told, Ken, is fabulous, of your history and your origins. Fantastic.
Yeah, yes, as a matter of fact, once I started into that, I started off as a surgeon treating these problems surgically, and I found that I could actually treat them medically.
And I'm a surgeon as well. So the question is not whether surgery is necessary or not, but because surgery in some people is necessary if they're not able to, like this cohort, sustainably carry on the behavior. So but the surgery is there as a tool, not as an endpoint. And so many people do surgery or put somebody on Ozempic as a single mode of therapy, and they fail. They may lose some weight, their diabetes may get transiently better, but they fail because they haven't changed the underlying relationship. And what this paper also speaks to is it's about your use and your relationship with a food spectrum. These women have decided that this, for whatever reasons, that their way of life, the ketogenic food spectrum, is what makes them feel the best. And then they experience the opposite. And what Zoe said in her commentary was so valid, is a follow-up here would be a subjective report. Did you feel, I'm going to use a Latin word here, did you feel crappy when you're in P2? And that really, because if you live in P2 and you're crappy all the time, you don't know what better feels like. And then you go get into keto and you start to feel this magic kumbaya, my inflammation's gone. But the absence of harm is less measurable than the presence of harm if you've been healthy. So, Zoe, I don't know if you read through that, didn't you? You know Zoe well. Yeah, and she's just fabulous, Zoe Harkin. But she says here that how well did they perform cognitively? And that's a valid clinical question, because you can then
Well,
use that.
we had our participants record, you know, what time they went to sleep, how frequently did they have bowel, like, you know, every day, just record.
Yeah.
They on their, because they recorded it daily, and we know that because it was logged on a drive that was shared, so we could actually see it logged daily. You know, so it was really real time. You know, did they sleep well? How do they feel? Mood. So to actually register all of these, as well as bowel movements and feelings of hunger, things like that. And when they came into the labs at the end of each phase, they did 2 mental health questionnaires. One was the WHO's and the other one was the NHS. So we do actually have a lot of data on that, which again needs to be analyzed and written up and things like that. So we do have a lot to investigate into it.
Right, and that, you know, again, God, we can talk forever, but Stephen Cunane did some brilliant work. You know, Stephen Cunane he's a Alzheimer's researcher in Canada. And Stephen did some brilliant work on the reversal of MCI in people with PCOS. And what would be, and again, the MCI and PCOS category is different from the women that are more diabetogenic. They don't have that MCI. Even though their insulin levels are high, the insulin levels are here, but their blood sugars are higher. So we've looked at that side of things in the reversal of PCOS, the reversal of mild cognitive impairment, which is what MCI is. And there are studies you can look at. I'd be very interested, again, in the division of this cohort, if they did in P1, P2, and P3, a cognitive impairment study. Because what Stephen showed, and now this is a short duration, but he showed over the course of, I think it was 6 or 8 months, he showed cognitive impairment in young, average age was, I think, 21 or 22 of the women with PCOS showed cognitive impairment, put them on a ketogenic diet, cognitive impairment measurably went away, and then when they stopped the ketogenic diet, it came back. And that's a precursor to the Alzheimer's.
Yeah, I mean, you know, again, because it's coming from the other direction, it's coming from, you know, having, I mean, PCOS means you've been hyperinsulinic for a fair amount of time.
Yeah.
And so, you know, going in a ketogenic diet and sort of like having that sort of like, a lot of people actually talk about, wow, it's like the light bulb turned on all of a sudden. You know, we did constantly ask our participants if they found that there was, you know, difficulty in focusing, difficulty, just any sort of discernible, noticeable difference that they can think of. And it didn't appear to be the case. You know, this is subjective, obviously. It wasn't done by some special testing. But that said, you know, again, they've been ketosis for a fairly long time, and
I don't think you'd see that in 21 days.
Exactly. You know, again, you know, if we were to understand this evolutionary, why would they suddenly become mentally impaired in 21 days? I mean, if they were drinking vodka all day for the 21 days, maybe that would be a different story. You know,
but, nobody evolutionarily, unless you're an Egyptian, you know, nobody lived in hyperglycemic hyperinsulinemia perpetually. There were transient periods, but you could come out of that, and there was a survival advantage to that.
Yeah, exactly.
You know, so again, these are all just wonderful things to talk about. But it's probably past midnight now where you are, so hopefully we'll blow this up a little bit.
Thank you very much. Thank you. Really appreciate it. And for the
any other comments from you, Ken, about all of this?
Oh, this has really been terrific, and Isabella is a very unique person.
Thank you. Well, you know, you say all of that, but you guys were leading. You guys, I mean, actually, it's really important to say, you know, I spent years reading you guys, your work. I could only come up with this design based on all of those studies and those publications you guys did. Literally, I'm not joking, reading your papers, reading all those other big names and reading their papers and understanding this massive puzzle. So it didn't come out of like, you know, out of the sky and drop into my head at all. There was a lot of background reading and studying of all the hard work that you guys were doing well before me. I'm really truly a newcomer to it in comparison, and it's just, you know, each of us trying to build on it and having that integrity to go, oh yeah, maybe I should have done that, and maybe I should have done that, and each of us challenging each other and say, well, how do you know that that's good or that's not bad? And you know, I do appreciate that, because I want to know the truth, not I want to get, you know, be proven right in that respect, and that's really learning from you guys, and genuinely I'm really grateful for that, so thank you.
just one other thing is I just did the Swiss Re conference in Switzerland a little bit ago, and Swiss Re is an insurance company. And what they're looking at is risk analysis. To be able to do this testing on potential both health and life insurance patients is going to give you a far more accurate estimation of risk in terms of, are we going to have to pay out on your life insurance policy over 20 years or not? And to my mind, this kind of study is going to refine not only the insurance industry, but then okay, if this is who you are, this is your premium. If you improve these numbers, we can reduce your premium because we're not going to pay out on you. So there are so many ramifications of this, but unfortunately, the world doesn't care.
Well, Keto Live, which has a relationship with Swiss Re, so they're looking to, to push that. Exactly what you've described in terms of working with insurance, because it's the insurance companies that their bottom line is to actually look at those things because it'll actually make a difference for them in that respect. And so that's the project of Keto Live, which obviously Adrian and David, Nick Norwitz and them are involved in.
Sure. And I mean, John Schoonby is the guy. He's the medical director of Swiss Re, and he's the guy that set this up. But here's where I was going with this. To my mind, a summary, obviously the 31 pages, but a brief summary of a study like this, focusing more on the biomarkers. One of the sponsors, the co-sponsors of this conference in Switzerland, which was a very high-level conference, was the British Medical Journal. And the editor-in-chief, his name is Khan, I can't remember what his first name is, but he was actually there for the entire conference, and he's very heavily invested in the space. And I spent quite some time talking with him, and I said, look, your journal doesn't allow us to publish this work. Mm-hmm. And he said, no, come to me and we will push the narrative. And again, it's an uphill battle, but it is not unreasonable to submit a summary of this data in a more, we did the study, but these are the biomarkers that we should be looking at kind of message. And submit it to something like BMJ with attention to Dr. Khan, and he may favorably view this and get it published at a tier 1 type journal, if that makes sense, because this data is just too hidden. And no, CNN is not going to pick this up. They'll pick up the fact that eating red meat causes diabetes, as that, but they won't pick up this beautiful paper. But BMJ would think about it. And again, I just, the worst that can happen is they say no.
Yeah, I mean, we did, Ken and I published in the BMJ Open Heart recommending a ketogenic diet for COVID-19. In actual fact, it was a paper that was, half of it was, I think it was like 5,000 or 6,000 words long, and half was on the biochemistry, pathophysiology, people basically hyperinsulinic who are at risk of hypercoagulopathy, DIC, and then, a clinical recommendation, which was essentially restricting carbohydrates, where you would end up being in ketosis, but there wasn't an aim to be in, therapeutic ketosis.
Right, but the focus there is on the benefits of ketogenic diet.
But we were including like some basic markers to look at.
Right, but the audience isn't ready for that yet. What the audience might be ready for is, this is a more effective evaluation, particularly because of the markers that you have here of early cardiovascular risk. And that is what people are interested in.